Thanks. I think I'm probably nearly unique in the room today by virtue of the perspective of distance and time in looking at the way the trial system is looking today already, 2 years or so after the IOM recommendations were made. And I have to say, I'm really impressed at how much progress there has already been. And of course, it's a testimony to Jim and Meg and Jeff from NCI and their colleagues, and also to Monica, Bob, Wally, and others from the cooperative groups. It's also, of course, a testament to the fact that there was a system that was in crisis in an important set of ways, as the IOM committee identified. And that has meant there's been a kind of joint national sense of purpose about doing something. That's actually where the UK system arose as well, out of a crisis. In that case, it was a crisis in the cancer care system with bad outcomes compared to many places, and that led to reorganization of the entire NHS facilities for cancer into a kind of primary, secondary, tertiary set of defined referral pathways for every region of the country. And it was on top of that that it was realized that a clinical research network could be piggybacked, and that was the way forward. But that same set of crisis and national purpose was clearly there. Sorry, try the other one, okay? So I'm going to try to talk about what the system is a little bit, what it's accomplished, some of the differences that may be evident, some of which will seem to be strengths or, in some cases, disadvantages. And I don't know whether any of these lessons are really transferable or not, but that'll be part of the discussion. I don't think I can avoid this, so I will walk you through some of these. First of all, this relates to the phase 2-3 structures. The phase 1 trials primarily proceed, and other pilot sorts of research proceed on their own. But the phase 2-3 structure is a national network. And network is used in two senses in the UK, so my slides don't confuse you. The 32 regional entities in England are called networks, and the totality is called a network, and that's not very helpful. The NCRI, the National Cancer Research Institute, is a very important entity in that it is a partnership of both the departments of health in the 4 nations that make up the UK and the big research charity funders, of which there are several, and they make a big impact there. And they meet regularly and jointly to sort of establish some things in terms of research priorities, but I think not at the same level of detail that we've been talking about for CTAC. But to look at priorities as a whole and to coordinate what is needed. Some of what is going to be needed is going to be within the potential gift of the government programs, others is not. And those things are, and they have a forum for working those things out. NIHR, the National Singular Institute for Health Research, is an entity that came along after the NCRN, and it was an attempt to, among other things, expand the clinical trial success in cancer into every other sphere of clinical research. It also took over a large part of the actual funding, research funding, which makes it more similar to NIH in general. Very importantly, the infrastructure funding for the clinical trials has originally had an entirely population-based component. So every one of those networks was receiving funding to hire research staff solely to do research, and we may talk about that some more later. And that's how the system started up. Now, in recent years, it also has an activity-based funding component too. So there's a complex algorithm for the funding, but there's both components remaining. Cancer Research UK is the 800-pound gorilla of research funding over there. Medical Research Council used to do a lot of the clinical trials funding, but now is concentrating on centers and biomarkers and translational technology, with most of the clinical trials funding coming through NIHR. The clinical studies groups we'll talk about. Those are our equivalent of the disease groups. And the clinical trials units, or CTUs, are the equivalent of the cooperative group coordinating centers and data centers. So that's England and the other countries. And you can see one of the things is that the distance is very important over there. And for those people who are living in the Kyle of Loch Alsh up there at the top, or in rural Wales, actually are quite some distance from the tertiary centers. But the pathways are well defined, and it is mandatory in the health system that there is consultation for everybody with cancer all the way up the line as necessary. So trials funding, first of all, and most importantly, virtually all of the clinical costs are just absorbed in the NHS, and the same is equivalent in the other countries besides England. It is literally considered part of what the National Health Service is there for, is to do clinical research, which is a view that didn't exist 12 years ago, that really evolved around the time that the cancer operation was set up, but has really become ever more firmly embedded in all of the constitution of the NHS most recently. So the infrastructure is funded. That means primarily research nurses and data managers at hospitals. Since they're deployed regionally, it may be that in some places, well, in some places they're deployed primarily at major tertiary centers, because that's where a lot of the activity is. But also in the tertiary centers, they have other resources whereby they can deploy those nurses, often from commercial studies and commercial income and foundations and so forth, so that they may disproportionately deploy the research staff that is paid for nationally out to the smaller centers where they can feed patients in. Some of the clinical trials units receive core funding. That's by competitive 5-year review, but there are a lot of other places that sort of manage on a shoestring. The clinical studies groups, that is the disease groups, have a budget that's completely negligible. It just pays for them to meet every so often. Every trial competes for its own individual peer review, either by one of the government funding organizations or by one of the major charities. And it has to be the research charities. In order to use all these NHS resources, they have to have a research plan and prioritization that they use for their funding decisions. That means that the actual grants per study are fairly small. They are really only to cover what the trials unit does centrally for the most part, and they usually don't have to put much money actually out into the individual sites. This is the Cancer Research UK set up for peer review. You'll see they've got a committee called CTAC. So it's like cricket and baseball, that any concordance of terminology will be misleading, so you should avoid thinking about it. But it covers the whole gamut of research, of course. The clinical studies groups are not the only way that clinical trials make it into the system, because any individual can apply for a grant to do any trial, and they'll have to work with a CTU to do it, and some do, although we found that with time and as this system has matured, 80 to 90% of the studies, even if they arise from somebody who's not on one of these CSGs, they will be fed into the CSG. There will be a sort of discussion of it and refinement of the idea, and it'll be put through as a sort of joint proposal. The membership of all the CSGs is rotational, mandatory rotational. Nobody can stay on it for more than 6 years, and nobody can chair it for more than 5 years. The terms are 3 years, and they're renewable, with the occasional exception of some very rare disease types where we've simply run out of people and we had to make an exception. It has the makeup you would expect with clinical and scientific members, and patient and public, as we call it here, patient-public representation, which started again in cancer, hardly existed before this system was put together, but has become a very strong element nationally since. These committees oversee all the whole portfolio of existing studies in the disease, whether or not they really developed it from the beginning. And they provide expert advice to all sorts of entities and interface with industry for feasibility issues and consultations and so forth. They also oversee specimen resources, at least the best organized of these operations do, and then there's a lot of collaboration around specimen resources on a national basis where that happens. It doesn't always happen. So these are just the names of the various groups. You can see we've got, for reasons that are obscure, many in GU rather than one, 2 in GI rather than 1, and some other odd arrangements which are all historical. PPI in the center is patient and public involvement. And then we've got cross-cutting groups, as you would expect. And every one of the groups publishes their trials portfolio, because these studies are all potentially open to any site in the country that's qualified to do them. And so they update their portfolios and put them on the web so that everybody can see what studies are available. And there will be processes within each network to try to review what studies are coming along and how interested they are at a particular hospital or within a particular network to put their resources into that study. The CSGs all undergo peer review in a way every 3 years. Now again, since there's virtually no money involved, this isn't really, you wouldn't see this. I went over there when this was first created, and I thought this was going to be ridiculously useless peer review, because there was no money and it wasn't going to be a very elaborate process and it wasn't going to dissect trial by trial. And then what good could it do? In fact, I think it's actually been very useful because it is inherently advisory, which means that both the group reviewed and the advisors go in there with the aim of having a dialogue and really just sort of taking the opportunity, the most important opportunity in peer review, for them to look at themselves and decide where they're going and what they might want to change or how it might look to others, to get some feedback on that and get some advice that almost certainly they can reject if they need to, but they may want to take under consideration. And especially as there will be changes in leadership in each one of these CSGs every 2 cycles or so, that external review can be very helpful in the incoming chair then making some changes as he may feel is necessary. We always have a reviewer from North America and a reviewer from Europe to give an international perspective on these things. Only one of each, because that's all we can afford. It would probably be better if we could have more. There, as you again would imagine, tighter integration of translational research into clinical trials keeps coming up and will for some time as an important element. This is one of those obligatory circular diagrams that everybody has shown you. And I guess the point, I guess some of the points I would make is that research is part of what we call the service networks, that is the cancer care delivery networks are obliged to provide. And that is probably quite important, as is the upper left corner, the involvement of the funders and the government itself in trying to make this system work. There's been a lot more commercial interaction in the NCRN than there was at the beginning. There was none at the beginning. It was an academic-only network. Now it has a major component of commercial trials that are within it, and more importantly than that, it has something like half of the big trials also have some pharma support as well, which makes a big difference in keep making them go fast. And the clinical trials portfolio overall is now 650 trials. So the original aims of this, when it was set up in 2000, 2001, was to double the accrual of patients in clinical trials over 3 years. Now, they use as the metric for that the incidence of all cancers except non-melanoma skin cancer, and that was the best we could do to test against. And actually, in this room in previous years, I showed us probably this exact slide, which showed what happened over the first few years, which was quite dramatic indeed in terms of raw numbers, and led to this article in the JNCI, and has continued, in short. So this looks, I'll break this down so you can see a little bit better, because the left is England and the right is the UK, and the reasons why we have to look at these things differently you don't want to know about. But we have to do it all the time. So I'll go into England on its own, and this is what's happened over the whole period of time. And you can see that the latest partial year will probably be something like the year before. So we're at about 23% against national incidence in terms of people going into clinical trials, which is actually mind-boggling to think about. Now, there is hidden in this the very important distinction between RCTs and non-RCTs. So this system was set up in such a way that a lot of places that had no experience with research were coming into clinical trials. I'll talk more about that in a second. But these are not like the CCOPs. These were places that just didn't have any experience with clinical trials. They're not just in the community. They were community and unequipped and unexperienced. And so there was a conscious attempt made to bring more non-interventional and observational studies into the portfolio, quality of life studies, a lot of specimen collection studies, in recent years, very heavily a lot of genetic studies. They were brought in part so that these smaller sites could get experience in filling out forms, auditing, understanding what needed to be done, building up staff that had the capabilities so they could be moved into intervention trials as well. But both parts have continued to grow, and a lot of phase 2 work that wasn't there at the beginning has grown, so that the non-RCT component has grown a lot. But if you convert just the RCT numbers on their own, and that's about 7.5% against incidence, that's about 19,000 patients in a country of 50, in England, of 50 million people. So it's almost the size of the cooperative group effort as a whole just now. Now, a few years ago, we had pretty much reached something that looked like it was plateauing. And the CLRNs, for Comprehensive Local Research Networks, that's when England decided it wanted to build something like what cancer had. They wanted to do it for everything. And of course, everything wasn't ready for it. Most areas of disease weren't ready for it. But they put a lot of money in and potentially a lot more staff, and that's when they activated the activity-based component of funding to a region, which meant that suddenly the cancer networks, which had kind of begun to run out of resources, didn't have any more for more trials, suddenly found that they could access some of these more generic resources that were available to them in the area. And so there was yet another burst of increased accrual, which is actually, I would have thought we had pretty much saturated what we could do. And it turns out it was just a financial thing. We could get more people in there and we could do more. And that's how it's played out. So this is a breakdown of the Cancer Research UK portfolio a bit in terms of late phase versus the feasibility study grants are mostly phase 2 studies as such. And there are some sample collection grants. The numbers of grants, it's fairly large. The clinical trial support as a whole, as you can see, Endorsed means that these are trials that didn't ask for a grant from CRUK, probably had some money from a pharma source or a foundation for the trial to go ahead, but they still got peer reviewed before they could go into the portfolio and utilize all these resources. But where the green line starts to rise is where NCRN came in, and that's how it's moved forward since. And as I said, we've had the buildup of commercial trials within this network as well, in the lighter color on the bottom. You can't read that. It's just that there are a lot of studies in most categories, in most diseases now. We've built up a fairly substantial portfolio, which doesn't mean everything is equal. I'll show you another way to look at that in a second. So I think we've reiterated a lot of these points already. The numbers are very good. The raw numbers are very good. I would make the point that the initial expansion of activity that I showed you was greatest in what's called the district general hospitals, the community hospitals that weren't previously research active. And that also was primarily in the non-interventional trials initially, and then in the phase 3 trials, but not so much in the phase 2 trials. The most important driver of success for this whole system appeared to be the new research staff that we're putting in place, who were very carefully ring-fenced. The hospitals were not allowed to use those research nurses, for instance, for ordinary cancer care delivery function, which they would have done because they are quite pressed on that subject. But they can't do it, and so we've been able to build up that way. I can't but agree that one of the things that has led to the success is the fact that in the NHS, novel agents are only available in license, and until recently, they weren't available then until NICE also approved them to be cost effective. Nowadays, that's not the case. There is a special fund that allows agents to be used once they're in license. But they still can't be used outside license, and that probably makes a big difference to how likely patients are to want to participate in clinical trials and how likely clinicians are in the same respect. The size of the UK does favor nationwide collaboration, which in most cases we're just big enough to do large-scale trials on our own, and not big enough to do too many competing trials on our own in most diseases. Very important about the NHS acceptance of the role of clinical research. Clinicians in the NHS get an annual review. They have to sit down for a performance review. And nowadays, and for recent years, they get actually asked they get checked on how much they are participating in the clinical trials that are available within their network. And they actually, they lose a certain face if they haven't done that. Not only to those people who are supervising them, but also to their peers. So there are league tables of these things in the UK. People pay attention to the fact that if you're an oncologist and you don't participate in clinical trials, which are available because they have to be in your area, it just doesn't look good. The funders work hard to prevent there being too many competing large-scale trials. That doesn't mean there are none, because clearly in large areas there are competing trials, and that's okay. But they do look carefully as to whether they think the extra capacity is there for the second one on top of one that's already in place. And the different funders do coordinate behind the scenes when they receive new applications to make sure that they're not working too much at cross purposes. The funders also are careful to look for whether research questions are considered important to external peer reviewers. And they use international peer reviewers at the concept stage virtually across the board. Occasionally, there'll be a situation where that's not really germane, but they will then still look for a sense that the CSG, on behalf of the national research overview does feel that a study is the important one it wants to collaborate on together. And so they can get around the international issues when they don't apply. Each regional network can select the trials it wants to support. Any trial is open to any place as long as they're qualified for it. As I said, they have league tables and they have targets, and they are supposed to be held to those. And the smaller community hospitals tend to participate in the non-interventional trials for the most part, but they do refer lots of patients elsewhere for the interventional trials. So just one or two more points, and I'll try to wrap up. The national coordination of this on behalf of virtually every component of the system is, I think, very strong, and they all do involve the CSGs in their discussion. So whatever happens on a national basis in relation to a particular disease, the CSG is a key resource to them and are always a party at the table. The individual trials have very recently been required to meet particular time and target metrics, which we did not have. Didn't seem to much need early on in this system, but of course every system is getting squeezed, including this one, and so now we have those metrics going in place as well. So some of the challenges include maintaining momentum in the face of considerable capacity and an increased burden of patients who, on prior trials, who are in follow-up, who are now using up a large part of our resources. The numbers seem to suggest that there are at least 2 or 3 patients in active follow-up that every research nurse is following for every new patient they're seeing. And so this is getting to be an issue that we have to cope with. Some of the more important studies are, not surprisingly, more work-intensive than the less important studies, and the networks are squeezed, and the economy is squeezed, and they are tending to activate easier studies. So we may have to introduce some sort of a weighting or points system into our work. Studies in rare disease should be a UK strength by the nature of our system, but the metrics of the system and everything natural puts them at a disadvantage, so we're going to have to find a way to overcome that disadvantage. One of the disadvantages is where we have delays in activating trials. Just as you've had here, we've had major delays there, which are not at the level of the IRBs, or the research ethics committees, as we call them. We have a central research ethics committee system that works beautifully. That's been terrific. What's happened, however, is that the individual regulatory governance of each NHS organization, every one of which is separate, has foundered on this business of their having to review everything for risk to them. So we are now in the process of having to develop a national program for that to get around that. But the Department of Health has given a lot of support for that to try to get past that. So we've had our delays in approvals, and the delays in approvals affect in particular rare disease trials, and hopefully we'll get around it that way. As I said, it isn't ideal. I've just shown that the 7.5% of randomized trial participation is primarily in breast, hem-onc, colorectal, and lymphoma. Everything else is below that, and so that's one of the reasons we've got to make it better. And my last slides were just about how we're going to try to overcome some of these regulatory obstacles, but I think I can stop there.